right, thank you all. Can everybody hear me okay? Okay, terrific. Thanks for moving quickly. And since you don't know me and you haven't seen me at all today, just kidding. I'm Leisha. I'm the executive director. So I'm really glad that you're here today. So I know there's still some folks coming in, so I'm going to go ahead and welcome and introduce all of our panel members. So I'm going to start off by introducing Dr. Dakota Schumacher. So Dr. Schumacher is a board-certified neurologist specializing in movement disorders at the Texas Institute for Neurological Disorders, also referred to as TIND, T-I-N-D. Dr. Schumacher earned his Bachelor of Science in Biology, graduating cum laude from Baylor University. He went on to complete his medical degree at the University of Texas Medical Branch in Galveston and completed his neurology residency at Vanderbilt University Medical Center, where he was elected academic chief resident for the 2022-2023 academic year. He continued at Vanderbilt for fellowship training in movement disorders, gaining advanced expertise in treating conditions such as Parkinson's disease, essential tremor, dystonia, and other complex motor disorders. Board certified by the American Board of Psychiatry and Neurology, Dr. Schumacher sees patients at TIND's Arlington and Grapevine locations. He is affiliated with Medical City of Arlington Hospital. In addition to his clinical work, Dr. Schumacher has published research on deep brain stimulation in Parkinson's disease and dementia care. He is an active member of the American Academy of Neurology and the International Parkinson and Movement Disorder Society. Please help me welcome Dr. Schumacher. And next we have nurse practitioner Julia Wieck. So Julia holds a Doctor of Nursing practice degree and is board certified family nurse practitioner in the Department of Neurology's Movement Disorders Clinic at UT Southwestern's Dallas and Richardson facilities. She earned her Bachelor of Science in Nursing from the University of Texas Medical Branch in Galveston in 2011, followed by a Master of Science in Nursing in 2016, and a Doctor of Nursing practice in 2017 from the University of South Alabama in Mobile. In addition, she holds a Bachelor of Social Work from West Texas A&M University, and Julia has worked in the field of neurology since 2012 and is a member of the American Academy of Neurology. Please help me welcome Julia. And lastly, we have registered pharmacist Beth Jacobs. Beth Jacobs is a retired pharmacist with a distinguished 40-year career dedicated to patient care across a wide range of pharmacy settings. Originally from Cleveland, Ohio, Beth earned her Bachelor of Science in Pharmacy from the University of Arizona in 1978. Following graduation, she relocated to Dallas, where she became a registered pharmacist in January of 1979. Throughout her career, Beth brought her expertise and compassion to inpatient hospital pharmacies, independent and corporate retail settings, mail order services, hospital-based retail, and specialty pharmacies. She developed a particular focus in hospital-based retail pharmacy, supporting transplant patients, and later specialized in the care of individuals living with HIV. Her dedication in this area led her to become a certified American Academy of HIV medicine pharmacist. She retired from active pharmacy practice in February 2018. Beth was diagnosed with Parkinson's in 2011. True to her lifelong commitment to service, she continues to give back to the community and has served on the DAP's Board of Directors since 2022. Outside of her professional and volunteer work, Beth enjoys a vibrant and active retirement. Her hobbies include hiking, swimming, exercising, cooking, reading, scrapbooking, and traveling. She met her husband Dennis in 1973, and together they have two sons, Matthew and Scott, and are proud grandparents to 3 grandchildren. Please help me welcome Beth. Okay, I'm going to go ahead and begin with our first question, and I'm going to start off with Dr. Schumacher. So our first question is obviously around medication. There are several medication options for Parkinson's disease, including carbidopa-levodopa, as you might know as Sinemet, dopamine agonist, and MAO-B inhibitors. How do these medications differ in their effectiveness, and in what situations would you choose one over the other?
Can you hear me?
Gotcha.
So first, I want to thank everyone for coming, and I appreciate the invitation to be a part of this. It really means a lot to be here. And so I would say in regards to the medicines in Parkinson's disease, ultimately it goes down to what is the root cause of Parkinson's disease, or at least the motor features that come with Parkinson's disease. And as we may or may not know, it's ultimately due to loss of neurons in the brain that are producing dopamine, right? So with the loss of that dopamine, it's bringing your cardinal features of your stiffness, your slowness, your resting tremor, your gait abnormalities, as well as facilitating some of those non-motor features. And so all of the medication treatment options for Parkinson's disease are all based on this lack of dopamine and how do we replace it. Though carbidopa-levodopa, some people know it as Sinemet, some people know it's ropa-dopa, some people know it as that little yellow pill, some people know it as a bunch of different names. Since that medicine has been around since the 70s, it is unfortunate/fortunate that it still is far and away the best medicine when it comes to Parkinson's disease management. And really all the medicines, in my opinion, are in relation to carbidopa-levodopa. And I think for almost every patient, you can use that as a cornerstone. Now, with carbidopa-levodopa, there are various formulations that come with it. The controlled release, Rytary, Crexont, Dehivi. There's been a whole bunch throughout the years when it comes to carbidopa-levodopa. But the traditional Sinemet, carbidopa-levodopa, little yellow pill is the cornerstone of therapy. The other medicines have their places, both have their own different side effect profiles. So with levodopa, one of the biggest side effects that may force us to try something else is that it can cause nausea. And a lot of people will struggle with nausea, and it sometimes takes a while to get through that. And so because of that, sometimes we end up having to use the dopamine agonists, which still act on that dopamine receptor, but it's a different molecule. Because it's a different molecule, it does have the possibility of causing other side effects. It's a little bit more likely to cause impulsivity, hallucinations, leg swelling, these things called sleep attacks, which are kind of poorly understood. But for some people, it's the thing that works for them. And then with the MAO-B inhibitors, so rasagiline and selegiline, Azilect, and I can't remember the other brand name, those are, the goal of that medicine is how can we stop the breakdown of dopamine so that way more of it is available for our brain. So that's a good adjunctive therapy for Parkinson's. It's also a good therapy for people that are early on in the diagnosis of Parkinson's disease. It has its own risk of side effects because it is increasing your dopamine levels, so it can cause hallucinations, impulsivity, and it has its own things like a flu-like reaction, headaches, things of that nature. There's a wide array of medicines. So there's MAO-Bs, there's the COMT inhibitors, so entacapone or apicapone. There's medicines that the molecule looks like caffeine. There's medicines where the goal of the medicine is to treat the side effects of dyskinesia that can come with levodopa. So there's a wide range of medicines that have various different mechanisms of action that can all be used in certain populations. But overall, I think for the vast majority of people with Parkinson's disease, carbidopa-levodopa is the cornerstone of therapy.
Thank you. So we know that there are, as you mentioned, a lot of the side effects. So can you talk about how to manage those? You talked about how at some point you might introduce a different medication, but if you are still getting the most benefit from one of these medications and still experiencing side effects, how can folks manage those well?
Yeah, I would say that is one of the more common conversations that I'm having in clinic with my patients is we're getting reasonable motor control, we're getting control of some of these symptoms, but we're having issues with tolerance of the medication. How do we deal with that? So again, going back to cornerstone therapy, the carbidopa-levodopa, again, far and away the most common side effect that we get with that is nausea. I will say that when I talk with patients who have nausea related to their carbidopa-levodopa, I try to really push them. Almost all patients with nausea related to levodopa, if they take it for long enough, then the nausea will eventually go away. So I'll have them take a half a tablet, even a quarter of a tablet, which I know my pharmacist friends would scoff at a quarter of a tablet, but it's just to make sure that we're having it in our system long enough so that the nausea can go away, and then typically doesn't come back at that point. If we're having other side effects from carbidopa-levodopa, so the other more common ones are dyskinesia, or that involuntary wiggliness or hallucinations, that is the patient's body telling me that we're at the top of their therapeutic window. Probably in a little later, I'll get more of a chance to talk about what that means as far as a therapeutic window, but that can then tell me, hey, do we need to lower the dose, right? So sometimes patients will come to me and they've been ramping up their levodopa, 1 tablet, 2 tablets, 3 tablets, with the goal of trying to make the medicine last longer. And I think that's actually a misunderstanding of how the medicine works. Increasing the dose does not change how long it lasts, per se. What increasing the dose does is it increases the peak effect. And so people come in to me on 3 tablets 3 times a day and they're dyskinetic. One of the things that we will do is we'll cut down the dose and make it more frequent, because usually the issue is that it's wearing off. And so that'd be one way to manage the nausea and the dyskinesias and hallucinations, those last 2 being kind of a peak effect side effect. For the other medicines, so like the dopamine agonists, with impulsivity, hallucinations, that can be dangerous. Now, for most people, when they start having hallucinations on some of these medications, it's not like big scary monsters or like you see on TV, people taking LSD or something like that, where you're seeing this psychedelic thing. They tend to start off as shadows in the corner of our vision. They tend to start off as misconstruing things at night, like a pile of clothes looks like a cat, or you'll see a little critter running across the room. And so, it's not an uncommon situation where I'm having to have conversations of, do we need to go back and try levodopa? Did we try our best with the agonist and now we need to go back to cornerstone therapy? Or do we need to try to reduce dose? Last case scenario, or worst case scenario, there are medicines to help treat the side effects. So there is medicines that are targeted for the hallucinations, specifically Nuplazid or Hemosirin is probably the best tolerated one. And so it's really, having a conversation with the patient and saying, how is this medicine helping or not helping? And how is the tolerance affecting us? And how can we kind of work around it? There's nearly an infinite number of things we can try, but we just have to be able to communicate and have those conversations.
Mm-hmm. Thank you. Julia, can you talk a little bit about the importance of seeing a specialist, a movement disorder specialist, specifically for Parkinson's? And especially, we know that over half of the population of folks with Parkinson's are not seeing a specialist. Can you talk a little bit about that relationship and when to seek out a specialist?
Sure. So sorry if, about my mask. I hope you guys can hear me clearly through it. I have a terrible cold, so I'm going to keep my mask on. Movement disorder specialists are specially trained neurologists who went on, like Dr. Schumacher, did a neurology residency where he, learned how to treat strokes and headaches and seizures and Parkinson's. But then when he finished that general neurology training, he went on to, get further training for movement disorders, Parkinson's being by far the most common one. So there are a lot of neurologists out there, a lot in Dallas, and they're good physicians, but they'll see you in the clinic, and then the next patient they see will be a seizure patient, and the next one will have terrible migraines. But Dr. Schumacher and movement disorder trained neurologists just see people with movement disorders. So the breadth and the depth of knowledge he has about these patients, just like you guys, is going to be more advanced, more in-depth than a general neurologist. And they're wonderful, and we're lucky to have general neurologists. But for a condition as complex as Parkinson's disease, I think it is very useful to have a movement disorders trained physician who knows the ins and outs and really everything about Parkinson's to go to as a resource. Some people's Parkinson's is very mild and they can get by with a general neurologist. Some people's Parkinson's is very tricky and advanced and more complicated. I really think it comes down to the level of comfort you have with the person providing your Parkinson's care. Are you comfortable with that provider? Are they listening to you? Do you feel you're getting good care from them? If If you've got questions about that, then I would definitely encourage you to seek out a movement disorders neurologist. I will tell you, I'm very biased. I think all Parkinson's patients need to see a movement disorder specialist. You can only benefit from that. But it's also a matter of how comfortable and the level of confidence you have in the person giving you care. I hope that answers the question.
Thank you. Yes, it absolutely does. And Beth, let's switch over to you. Are there any prescription medications, over-the-counter drugs, vitamins, or supplements that might interact with carbidopa-levodopa or increase some of the side effects that folks should be aware of?
There are actually quite a few medications that are over the counter to be alert to. The first is iron tablets. A lot of us don't even think about in your multiple vitamins that iron definitely will decrease the effectiveness of the carbidopa-levodopa. So, and then I'm just going to name a few and then tell you what they do. There's also the possibility of some diuretics and antihypertensive medications that you should be aware of, that if you're taking those, it could have an additive effect to the side effects from carbidopa-levodopa. So that could be something you need to be aware of and let your doctor know. Then if you're taking any kind of antidepressant or a antipsychotic medication, those two there's a side effect with the levodopa-carbidopa. So you want to be sure to be aware of that. Which brings me to an over-the-counter medication that I don't remember when I was in pharmacy that many people taking it, but I mean it still is available. It's St. John's wort. So I mean it works like the antipsychotics and antidepressant medications. So when there's an interaction with the carbidopa-levodopa. And then finally, I was noticing that with supplements, there's some of the supplements might have some amino acids in them, and again, that would interact with the carbidopa-levodopa in the same way that it would compete for the binding of it, and it decreases the effectiveness of the carbidopa-levodopa. So getting back to the iron tablets, I mean, it's not that you shouldn't take them. You need to separate them maybe by 30 minutes to an hour before you take the levodopa, or take the carbidopa-levodopa like an hour before or 2 hours after you take it. And then, because you don't want to decrease the effectiveness of the carbidopa-levodopa. With the diuretics and the blood pressure medications, I just use caution in taking those at the same time because, you know, you could have additive orthostatic hypotension and, you know, I mean, everybody has low enough blood pressure from the carbidopa-levodopa or the Parkinson's and you know, then you might get dizzier. So, let's see, then there's I would keep notes as far as the supplements, as far as, you know, let your doctor know because they could potentially interact with the medications.
Yeah, that's really helpful, for sure. Yeah. So, Beth, can you talk a little bit about some of the high cost of some of the Parkinson's medication? And we're all aware of just the cost of medications in general. What would you recommend patients either start to talk to their doctor about when they're filling a new prescription or getting something filled with their pharmacist? Where is the best place who is the best person to talk to about finding the most resourceful and least expensive way to get your meds filled?
Well, I would say that the drug companies have help if the medications are expensive, like on a new medication. If you have private insurance, they have copay cards that they can assist you with the high costs. The generic drugs, it's a totally different story. I would say if you have, well, let me start over. When you're getting an expensive prescription filled and you can't afford it, I would talk to the doctor to see if there's an alternative. That's really important because you don't want to not take your medication, and the doctor will find something that is affordable for you. As far as the generic medications, there are different generics that you can take, and some of them are more expensive than others, and some of them work better than others. So that's what, I mean, I would talk to the pharmacist at that point and ask them about, which ones they have. I mean, the insurance companies totally determine that as well.
Good point. Thank you. Dr. Schumacher, there are several clinical trials that are currently underway for Parkinson's disease, investigating potential new treatments and therapies. Can you talk about some of the benefits of participating in a Parkinson's disease clinical trial and where someone might find out how they qualify to participate?
Yes, I want to piggyback a little bit on what Beth said and emphasize the important thing that she said about talking with the provider about drug alternatives. That's why I emphasize, and my ringers in the crowd will probably attest to, this is why I emphasize the fact that carbidopa-levodopa is the cornerstone therapy. We all get into our own biases, we all get into our own situations, and so if we try to switch something to a branded drug or a newer drug to see if it helps, if it's not something that's financially feasible, it's always okay to go back to what you were doing before and continue to try to work on the stuff, because none of the stuff that's on the market right now is game changer away from the traditional therapy, carbidopa-levodopa, which has been generic for decades now, and has its own generic problems, as Beth was saying. So to the point of the clinical trials, I would say that I encourage all of my patients, and I encourage everyone here to look at clinicaltrials.gov. It is a database of all of the clinical trials that are getting current federal funding, and that is the most reputable source of a research trial. You will see things online, or you'll see commercials, or you'll see stores that'll say, what's the word I'm looking for? They'll say things like stem cell therapy for Parkinson's here, or this new therapy here, or we can do this procedure and do it here. But unless these newer emerging therapies are being done out of a academic center, being done out of a research trial, most of them, I hate to say it, are snake oil. They're taking advantage of misunderstandings of how some of these things work. And so if anyone is interested in disease-modifying therapies for their Parkinson's, if anyone's hearing something that's on the horizon, then checking out clinicaltrials.gov I think is a really good idea. Not only do they have disease-modifying trials, they also have symptomatic medication trials, they have physical therapy trials, occupational therapy trials, speech therapy trials, all sorts of things, caregiver things, any sort of idea. Last time I checked, there was about 4,000 or so entries for Parkinson's disease, and you can filter it by where you're at and interventions there. I would say that obviously the benefit of being in a disease-modifying clinical trial is if we do finally crack the code and we find a drug that does work and you happen to be in the treatment arm, well then you're getting disease-modifying therapy. Now, obviously the risk associated with that is these are clinical trials, and there's always the risk of side effects with dealing with some of these things. And so I think it's important that if we decide to pursue a clinical trial and looking into it, that we ask the person who is enrolling us to say, hey, where are we at in the data for this? Can you give me some insight into what risks am I taking? I think another added benefit of a clinical trial could come with the extra monitoring and extra clinical visits that you can get with a provider. So a good example of this is there was a famous stroke trial called Sampras. It's a long story, but essentially these people that were in the trial, both in the treatment arm and the placebo arm, did way better than the general population when it comes to their stroke care. And a lot of speculation to that effect has been that it was because they were getting daily phone calls from nurses. They were getting weekly visits with a physician or nurse practitioner or physician assistant. So they were getting more visits than they otherwise would. And so that is a potential benefit that you get with some of these clinical trials, is that you're able to see these professionals more regularly than you may be able to with your own neurologist or movement disorder specialist.
Very helpful, thank you. And DAPS always, we make sure we share any notifications that we get about trials. We share those during our educational series, and Keisha does a great job of making sure our instructors and our facilitators have that information to share and pass on to you as well. Julia, let's switch gears a little bit and talk about hospital visits. We know that the risk and the chance of a hospital visit, whether it's planned or unplanned, increases with Parkinson's. Can you talk a little bit about how you would recommend someone prepare for a hospital visit so that folks are continuing to get the kind of care and treatment that they need?
Sure. So I was a hospital nurse on the neurology floor for many, many, many years before I became a nurse practitioner. So I was in the trenches of the hospital taking care of Parkinson's patients all the time. And I will admit, I didn't know anything about Parkinson's. I knew far more about strokes and things like that because they were just so common. So I would get Parkinson's patients on the neurology floor in the hospital, and I knew they were going to be on carbidopa-levodopa, but I didn't know anything about, for example, how time-sensitive it was for these patients to get carbidopa-levodopa. So I think that is something that you guys can do to help educate nurses when you go to the hospital for whatever reason, is to stress to them how important it is that you get your medicine on time. Now, nurses are busy. When I was on the neurology floor, I took care of anywhere from 6 to 8 patients over a 12-hour shift. And while that doesn't sound like very many, all these patients have to get their meds at the same time. They're all morning meds, 8 to 9 a.m. When you've got 8 patients needing medicines at 9 o'clock in the morning, I can't be in 8 rooms at one time giving meds at 9 in the morning. So I have to triage, this person's here for a stroke, this person's here for this, because it's not all going to be Parkinson's patients. They're going to be epilepsy patients and stuff. They all got to get their meds at the same time. So if you can educate the nurses, and there will be a rotating, panel of them while you stay there about, hey, I need to get my carbidopa-levodopa on time. But the most important thing you can say is, and this is why. Because if I don't get my medicine every 4 hours, I cannot move, or I am shaking so badly, I'm in pain. Because all my patients will say, I need my medicines on time. Yes, I'm aware, but I cannot be in 8 rooms at one time. But if you tell me this is why, because I cannot move, I will not be able to function if I don't get it every 4 hours or whatever. Bingo, now I'm putting you at the top of my list when it comes to time for me to give all these 9 a.m. meds at the same time. I gotta go give it to Mr. Jones first because he's not gonna be able to move if I don't give it to him on time. So doing your part to educating these nurses the importance of the timeliness of the carbidopa-levodopa, but also giving them some grace. If you don't get your medicine right at 9 a.m., you gotta understand I'm probably coding a patient next door or giving blood because somebody's dying of cancer in the next room or whatever. So if I'm a little bit late, please give me the grace. But then also, when things feel right, explain, hey, I'm late on this one. I do need my medicine on time as best you can. I know you're busy. That's really important. But also, before you go to the hospital, I encourage all of you to make a list of your meds and keep it in your wallet, because it is such a mess when you go to the hospital figuring out what a patient is taking, and that's crucial to knowing how to, do your medications and everything when you go to the hospital. So get a med list, keep it on you at all times, and then stress the importance of getting your meds in a timely fashion, as best and as gently as you can.
Yeah, and it sounds like, you can't over-communicate with hospital staff. We all know that nurses are on shifts, so what you say to one nurse might not be what the other one heard. So over-communicate, advocate for yourself, and I really like that you talked about these are the symptoms that I will experience if I don't get my medicine within this time. And sometimes that could even be some memory loss or difficulty with speech. So know your symptoms and make sure that you advocate for yourself, for sure. Beth, let's switch over to you. Can you talk a little bit about how pharmacies determine whether a Parkinson's disease medication prescription will be filled with a brand name or generic? We've recently begun to get some of those questions from folks. Is there a difference in the quality between a generic and a name brand?
If the doctor is wanting a brand name medication, the pharmacist would automatically fill it if it says brand name medically necessary or dispense as written. Now, not to say that the insurance will pay for it, but I mean, they can certainly try in that sense. But now with generic medications, there can be a huge variance between manufacturers. So something to always be aware of when you do get your prescriptions filled for a generic medication, make a note of which brand that you're taking. It's typically on the label, and you can also identify the generic medication that you're taking, which manufacturer, by the numbers on the pills, or sometimes they have letters, or they actually have some names. There can be as much as a 30 or 35% variance between the generic medications' effectiveness towards each individual. Again, that's based on the generic drug has to be bioequivalent to the brand name drug. But that doesn't mean that the fillers and the tablet compression and the dyes in them are all the same. And so everybody, like what might work for one person may not work for another person, even on the same generic. So if you're on a particular generic medication and it's working for you, and you notice that the pharmacy changes it, and all of a sudden maybe you're having more symptoms, I mean, it may not be absorbed the same way, and you could end up having different side effects from it. So it's important to really know which medications you're taking. It almost is like a brand name drug. But there are also generic medications that are authorized generics. But I looked it up, and carbidopa-levodopa does not have an authorized generic, and that means the manufacturer makes the generic medication, so it's exactly the same as the brand name. I think that's pretty much.
Yeah, that's really helpful. Thank you. Dr. Schumacher, if the side effects of a Parkinson's disease medication become difficult to manage, like what we talked about earlier, is it ever appropriate to either reduce the dosage you mentioned or just stop the medication? We have a lot of folks that will come to us and say, gosh, the side effects were so bad, I just decided to stop. How do you feel about that? And as a physician, what would you recommend to a patient who's really struggling with those side effects?
Yes, and I want to piggyback off of these last two questions. So for Julia's comment, the communication thing I think is really key. The other thing, my wife was a neurology nurse, who's now a nurse practitioner as well, who was on the neurology floor. And so one of the things that I would do, that I learned from her, is patients can bring their own medications to the hospital, right? Now that does not mean you dispense your own medications, because that can be dangerous, because they could be giving you other things that could cause side effects. But if you bring your own bottle, you tell the nurse, they will print a patient label for you, and that way the medicine does not have to be tubed up to your floor. The nurse can come in there, scan your thing, and you can get your medicines a lot quicker. So along with communicating the importance of the nurse being timely and coming into the room, also asking them, hey, can I use my home supply and have a label so that we can get dispensed a lot more easily.
Especially Rytary, Crexont, those specialty drugs, most hospital pharmacies are not going to have those. So if you only like Rytary or only like Crexont or your specialty drugs, you need to bring those with you, because I guarantee you most hospitals will not have those. They will switch it out for regular carbidopa-levodopa. So if you want a specialty drug like Rytary or Crexont, bring it with you to the hospital. That's a good point.
Also the pumps, so Biolev and Anapco, the hospitals are not going to have those, so you need to bring your own supply and have a patient label. To Beth's point, this is more of a tongue-in-cheek comment, but I do appreciate what Parkinson's patients are. They take carbidopa-levodopa so often that they know the most minute details of their carbidopa-levodopa. So the shade of yellow, the glossiness of the yellow, the chalkiness of that particular tablet. So out of all, you know, in my time as a general neurologist and my time as a Parkinson's patients are the ones that are going to notice the difference in their carbidopa-levodopa to the most minute degree. And I love that. Okay, so to the question that was posed to me as far as can we, if we're having side effects, can we pull down medicines? Can we stop medicines? Yes. The good and the bad of Parkinson's disease is because we do not have a disease-modifying drug, everything else is symptomatic management, right? Everything else is trying to improve your quality of life. And if the medicine is hurting your quality of life, well then that's going the exact opposite of what we're trying to do here. And I alluded to this a little bit earlier, but it's not uncommon that people, as they get through the disease course, may have to reduce the amount of medicine that they're on because their disease is progressing and their therapeutic window is getting narrower and narrower. And to give a little bit of a better explanation of that, it's a little bit hard to do with a mic, but a little bit of a better explanation of that is, you know, when you are first diagnosed with Parkinson's and you have a bunch of your dopamine-producing cells still, then your therapeutic window is very big. So down here, we're stiff and slow and we shake. Here, the medicine's working. Here, we have dyskinesia and hallucinations. As we lose our dopamine-producing cells, and thus our brain acts even more on the exogenous dopamine that we get, that therapeutic window gets narrower and narrower. So if you originally were on, let's say, 3 tablets of 2500 carbidopa-levodopa per dose, maybe you were right here early on in your disease course. 5 years down the road, your window's here, and your level's all the way up here. So now you're getting more peak effect than you otherwise were getting. And so I would say that the notion that we got, that I got in training and that I see in my practice is you usually identify the amount of levodopa someone needs throughout the day in the first 3 or so years of disease if you're really pushing things. And then you spend the next 5, 10, 15, 20, 25 years fragmenting that dose out. Because we're having to constantly have to ride this line or do this more and more of a balancing act between not enough medicine, medicine's working, and too much medicine. Now, there are, I say that it's okay that we cut back or we stop some of these medicines. Does that mean I want you to cold turkey anything? No. I don't want you to cold turkey anything, and any decision that we made needs to be in concert with our provider, because there could just be a misunderstanding of what we think is a side effect could actually be something else that's going on. If you were on carbidopa-levodopa and you broke your leg, you're not going to blame the carbidopa-levodopa. Obviously, that's a facetious example for that. But there is a little bit of danger there. So, not necessarily with levodopa, though there are case reports. More so seen with the agonists. Abrupt cessation of high doses of dopamine agonists, so getting upwards of like 8 milligrams of ropenolol 3 times a day, can cause acute stiffness that can be life-threatening in case reports. I've personally never seen that happen. I haven't worked with anyone that has seen that happen, but it's in the literature and it's something that we have to know about. Levodopa less likely to cause that, but there is some case reports there. And with other medicines like amantadine or Gocovri, probably those are probably the most common ones that would have that. Yeah, that you can also have kind of a withdrawal syndrome if you abruptly stop that, where you can feel fluey and unwell and more lethargic for a temporary period of time. So yes, we can always adjust the medications or stop the medicines because we're trying to improve functionality. If the medicine's just causing us problems, then we need to get rid of it. But we need to do it safely, and we need to do it in concert and in a communication style with our provider.
Helpful, thank you. Beth, can you talk a little bit about when to take carbidopa-levodopa? Do you take it on an empty stomach? How long do you wait before you eat? Talk about the ideal way to take your medication.
So ideally, the carbidopa-levodopa should be taken on an empty stomach. But like we've heard earlier, the most common side effect is going to be GI problems. So you go, well, you know, quality of life isn't very good if you have an upset stomach all the time. So then it's best to take it with a small snack, like some crackers or some applesauce. You want to be very careful about taking it with a high-protein meal because a high-protein meal can really reduce the absorption considerably. They both compete for a place on the transport, to your, for the effectiveness of the carbidopa levodopa, let's put it that way. And so if some people don't have any kind of sensitivity to the protein, I mean, they're not protein sensitive, but most people are, so you want to check, if you're having symptoms of, wearing off sooner, it's because of the protein, the meals. So it's best to avoid that.
Yeah, thank
So,
you. Julia, can you explain dysphagia and how it affects people with Parkinson's? Specifically, how does it impact the timing, coordination, strength of the muscles that are needed for swallowing that might make it difficult to manage food, drinking, etc.?
Sure. So dysphagia, that's the medical term for trouble swallowing. Parkinson's is all about slowing your muscles. And it doesn't just slow your muscles in your arms and your legs. It can, with time, slow the muscles here. Your neck muscles, your throat muscles, your tongue, the muscles that are involved in swallowing. Swallowing is actually a pretty complex thing. Your tongue has to move things to the back of your throat, and then it has to lift up, and then this flap has to open so the food goes down into your stomach instead of down into your lungs, and things all have to work in concert perfectly, the timing and everything. I think it's a miracle more people don't choke whenever they eat. But in Parkinson's, whenever these muscles start to slow, it can slow, and one little, slow muscle can throw off the timing of this complex process that's happening here. Your tongue doesn't push the food back in a timely manner, and then this flap is getting the signal it needs to open, but the food's not back there right, or whatever, and then you can end up coughing, because things are starting to go down the wrong pipe. So it's something that we see more, I see more often, as the disease progresses and it starts slowing, these muscles involved here, but it certainly can cause problems with whenever you try and swallow pills or food, or more often liquids. That can be very tricky. And so a good speech therapist is a wonderful resource, because not only do speech therapists work on voice, they also work on swallowing a lot of times, and they can help you swallow more effectively with your slower muscles, and they can give you tricks and tips on how to swallow safely so that you don't get into that position where you're constantly coughing after you swallow something. So if that's something that's going on with you, definitely think about a visit with a good speech therapist.
Thank you. And Julia, can you also talk just about additional or maybe complementary therapy for Parkinson's, such as incorporating exercise, diet, nutrition? Can you talk a little bit about that?
Sure, yeah. So for my regulars in the crowd, you know that the one thing I'll harp on every visit is exercise. And I say often that exercise should be viewed as important as a medication for Parkinson's. It is super important, and one of the most common questions I get is, what can I do to slow down my Parkinson's? What can I do to slow progression? And that's it. Exercise is your answer. I see all my patients come and they say, I saw this supplement online, or this vitamin. They say that if I take it, it can slow my Parkinson's. Should I do that? And I say, you take that money that you were going to pay for this vitamin that this person is selling, and you put it towards a gym membership. That's going to reap you way more benefits than any supplement or vitamin is in terms of slowing the progression of your condition. Also in just, improving your everyday function. It's good for your muscles, it's good for your movement, it's good for your mood, it's good for cognition. Exercise is incredibly important. I can't stress that enough. And it's the only thing we have hard data shows that if people who engage in exercise, they generally have slower courses with their Parkinson's over those people who do not. So I can see it. The proof is in the pudding, and I have said this many times. Nothing will make me go jump on my treadmill faster at the end of the day than taking care of Parkinson's patients all day, because I can absolutely tell the ones who exercise or the ones who don't, they just do better for longer. And diet is important too, so cheeseburgers and pizzas are amazing and delicious, and we all should enjoy. But Mediterranean plant-based diets are shown to be very healthy, neuroprotective overall for not just Parkinson's, but MS and dementia and other things, other neurological conditions. So trying to, participate in that good, clean living of nice, healthy diets, limiting alcohol, tobacco, things like that will only reap your future self benefits down the road.
Thank you. And each of you have a schedule of all of the DAPS classes that are available in your communities, where we offer lots of amazing exercise classes. And on this coming Friday, we will actually have our Ask the Nutritionist, which is all via Zoom. And Faye Elahi is actually a nutritionist who also has Parkinson's. So she will absolutely provide some information that will complement some of the things that you've already heard. So with that, we have a little bit of time for some questions. So do we have any questions from the audience that you would like to ask any of our panelists?
Hello, does this work? Yeah, I have some questions about taking carbidopa-levodopa. One is, you said to watch out for interaction with protein in your diet. Should you limit your protein? Another question is, dealing with constipation, what about laxatives and do they interact with the medicine? And the third is about timing of not eating before or after taking the pill. Would that be 30 minutes to an hour? Do you drink water before or after? Those kind of questions.
Yeah, I was going to take a crack at that question, if that's okay. That is probably the most common conversation point I get, particularly with new patients. And Beth is right. So protein does compete with absorption in the small intestines for levodopa. And if it's not absorbed, it doesn't work. Obviously, it just stays in your gut. I would say, because for most people with Parkinson's, they're going to have to take it at some point in time more than 3 times a day. I ask them to prove to me that they're protein sensitive or not. So to me, I say, I don't necessarily mind taking the levodopa with food. And I tell them, hey, if you start to notice, just like Beth says, that, when I take my morning dose with my eggs and milk and steak, that maybe I don't get the same oomph out of my levodopa as my noon dose or my afternoon dose. If we start to identify that, then avoid it by 30 minutes one way or the other. But it's only protein that is the issue as far as absorption goes. If you happen to eat a more carb-based breakfast, like I begrudgingly admit I do, then eating it with a bagel or croissant or bread or whatever is not going to compete with the absorption of the levodopa. So I try to force people to prove that they're sensitive because it can be so disrupting to their day-to-day life. And then to your question of laxatives, one of the issues that it's common in Parkinson's disease is constipation. We've shown that constipation impairs the absorption of levodopa, and so I work very hard with all of my patients to try to make sure we are on some amount of a regimen so that we're having once-a-day bowel movements. Selfishly, from my standpoint, because I want them to absorb all their levodopa. Also, I want them to feel better and not bloated. So whatever you have to do, and often that ends up being Miralax once a day, and that's okay. Whatever we have to do to get to once-a-day bowel movements is going to allow your levodopa to be absorbed better.
Good question. Any other questions for any of the panelists?
I take a Centrum Silver multivitamin for women every day, but I've also read that I should take B12 and C, but then I've also read, don't take it if do take it, don't take it. What do I do? maybe the Centrum Silver has enough of everything, but I just want to make sure I get everything I'm supposed to get. Whoever wants to take it. Okay.
There, I would say that the B12 is, your question is, I'm not sure what your question is, should you take it or not?
I take the Centrum Silver multivitamin, but then I've also read I should take B12 and vitamin C also. Then I also read don't take B12 and don't take C.
Well, they're both water-soluble vitamins, so your body's not going to absorb any more than what it needs. I mean, I would think if you're taking too much of it, I've read that with B12 you can, take too much, but you would have to take a pretty high dosage before it would spill out. Wouldn't you agree?
Yeah, it would spill out.
Yeah, I mean, it's just not absorbed. Your body's not going to absorb more than it needs.
One of the things I hear that question, they'll ask, like, oh, I read that thiamine has benefit in Parkinson's and CoQ10 has benefit in Parkinson's and B12 has benefit in Parkinson's. Almost all of those datas are coming from observational or retrospective reviews of patients, and there's just not a strong database to support it. And for thiamine, for example, the studies that showed that thiamine slows Parkinson's motor progression, all the data panel or the data set was done outside the United States. In the United States, we fortify our bread supply with thiamine, so everyone in the United States is getting way more thiamine than anyone probably needs. It's not necessarily dangerous, but we're getting the thiamine that we need. So for people who come to me and they say, hey, I read that this study showed this, my response to them is, maybe it works, maybe it doesn't work. Our jobs that work in this industry is we're going to give y'all the things that have strong randomized controlled trial data. And the thing I tell patients is if it doesn't have that strong randomized controlled trial data, as long as it's not dangerous, as long as you're not spending too much money, and as long as you don't have unrealistic expectations, I'm fine with whatever. So if I was hearing Centrum Silver, try to take B12 and C, I'd say, I don't know if it helps or doesn't help. It probably won't hurt you, but if it were me personally, I don't think it's worth the squeeze. That was not a pun intended with the vitamin C.
And is there a recommended dose that is different from men and women when it comes to B12?
If people have B12 deficiency or even kind of close to it, I tell them 1,000 micrograms per day. I've never run into a situation of B12 toxicity. B6 is one that I commonly see people also take. That is one that I have seen too high and too low can cause problems, so I would not take vitamin B6 by itself.
Okay, good to know. Any other questions? Okay.
He's okay. Now they got it. I said vitamin D. They asked if vitamin D is okay, and I said yes.
Vitamin D is okay. That's a yes.
You'll find this funny. I'm a competitive croquet player. And you can't play croquet and have Parkinson's, so that's good news. I'm headed to a tournament in Houston in 2 weeks. And I have found in a high-stress situation like that, believe it or not, I sometimes increase my dosage of carbidopa, levodopa. I'll take 1.5 pills every 4 hours normally. Is there some amount that I can increase it? Because in those situations, it's like putting all day, you're putting, playing golf. Can I increase it without inducing the other word I can't pronounce, the shakes, uncontrollable movement, dyskinesia?
So I first obviously talk with the neurologist that you have, the provider that you have, but I do have many patients that when they get into stressful situations, when they have increased sympathetic nervous system tone, their Parkinson's symptoms will get worse, and so they will often have to take a little bit extra carbidopa, levodopa. There's no true dangerous risk of taking an infinite amount of carbidopa-levodopa, besides the fact that it can make your blood pressure drop and you can get hallucinations. To give you an idea, my mentors in training were practicing in the 70s and 80s, and what they would used to do before they had the intestinal dopamine is that they would put carbidopa-levodopa in a blender and blend it up and put a little bit of water in it, and they would like put it down a tube to give them the first intestinal dopamine. Now granted, though, they were a bit of cowboys. So I say that to say that even if you did take too much in a single setting, it would give you dyskinesia. You may have a hallucination, but that typically would only last a short period of time, 30 minutes, 45 minutes, and as you get away from that peak effect, it's going to go away. So yes, some patients do need a little bit of extra oomph in stressful situations.
And that's okay.
And that's okay, yeah. Because even if you got those side effects, they would be temporary.
Okay, thank you.
Okay. Let's see here.
I guess this isn't exactly medication related, but I'm very confused about the diagnosis of Parkinson's versus the diagnosis of Parkinsonism. Can anybody help with that here?
So yes, so Parkinsonism is essentially just a grab-all for anyone who has slowness, stiffness, resting tremor, or gait abnormalities that look like Parkinson's disease. Parkinsonism could encompass everything: Parkinson's disease, vascular Parkinson's disease, drug-induced Parkinson's disease, Parkinson's plus syndromes, normal pressure hydrocephalus, blah 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 blah. All of these syndromes, and so oftentimes. I would say I have seen where general neurologists will send people to me, and the only confident thing they can say is that they have Parkinsonism. They're not necessarily confident in saying that this is Parkinson's disease or not. As of right now, the clinical history and exam is nearly equally sensitive as the DAT scan and the skin biopsy at being able to identify if someone has Parkinson's disease or not. Now, in situations that are confounded, so people that have bad cardiovascular disease, people that are on dopamine blocking drugs like antipsychotics, or people that have brain swelling problems, it sometimes can say, well, is this Parkinson's disease? It kind of sounds like that based on the history and the timeline, but there's some weird things here, and that's where those new tests come in, so the alpha-synuclein skin biopsy test and the more traditional DAT scan. And so essentially, Parkinsonism as a diagnosis is ultimately a question mark to say, hey, we haven't quite figured out the diagnosis yet. And then once you spend enough time, history exam, and then potentially some testing, you can be more confident in one of those diagnoses.
So if you have the skin punch biopsy and it comes back as, let's say there's 12 symptoms for Parkinson's, and you have 9 of those symptoms, but your skin test comes back as Parkinsonism, is that also related to I can't think of the word, the loss of dementia? Thank you, whoever said that.
So the sign 1 test, they kind of crouch the way they write the reports. No one's supposed to have alpha-synuclein in their tissue, and so if alpha-synuclein is present, then you have one of those synucleinopathies, which include Parkinson's, Lewy body disease, multi-systems atrophy, or primary autonomic failure. So presence of that abnormal protein is 99% specific for one of those 4 conditions, and the company just doesn't want to be definitive on which one it has. It just says you have synuclein.
That answer your question? Thank you. Okay. We've just got time for one more question, but the panelists will still be available a little bit after. We've got another program that we're going to start in Asbury in just a few minutes, so I'm going to get one more question.
Yes, this has to do back to protein. I know we all think of proteins as just certain food groups, but lately I've been reading articles. I eat a lot of fruits and veggies, and apparently they have a lot of protein in them too. Will this affect when I do get onto the
Carpadova, Lepidova.
Are there specific types of fruits and vegetables you were thinking of that you've read about?
Huh. I mean, I know nuts. Say that again?
Like the amount that you're gonna protein in a steak is way like maybe fruit has a little bit of protein, but compare that to a steak or eggs or dairy, they're gonna have exponentially. That's the heavy protein. You can't. It's rare you're gonna be able to avoid protein at all times around your levodopa, but I would just say stay away from the heavy protein sources, meat, dairy, nuts, eggs, too close to the time that you take levodopa. But again, you can take them together. You're not gonna die if you take your levodopa at the same time as you eat your steak. It just may not work as well. You may be more shaky, slower, things like that. You'll get some absorbed, just not gonna get all that tablet. Maybe you only get a half tablet absorbed if it's too close to protein. Does that make sense?
Excellent.
It may not be absorbed as fast or for as long. I mean, that's the big key to it. And not everybody reacts that way, like Dr. Schumacher said.
Very true. Thank you all so much to Beth, Dr. Schumacher, and Julia Wieck. Very, very helpful. Please join us. We have 2 short programs back in Asbury. We have a music therapist that will be getting very shortly, followed by Dr. Ray Dorsey, who will be talking about his New York Times best-selling book, The Parkinson's Plan. So hope that you will join us back in Asbury. Thank you.